All right, so we're going to wrap up here with diabetes, obesity, hypercholesterolemia, and hypoglycemia. So admittedly, none of us see kids that are obese in our practice, but we'll touch on it anyway. Diabetes is one of the most serious and challenging endocrinopathies. If I could tell you that there's anything that I would love for it to go away in my practice, meaning that it didn't exist anymore, would be diabetes. It's just a devastating disease. It's just a horrible disease for anybody, particularly kids. But that being the case, I will tell you that it's been very inspiring in my practice to see kids who take a difficult challenge like that and do the best they can with it and move on. So there are a lot of kids in that have diabetes that do very well with their diabetes and also in life. It's just a disease that shouldn't be such a burden to folks, but it is. The prevalence of both autoimmune type 1 diabetes and non-autoimmune or type 2 is increasing. Although effective, we have treatments for diabetes that are costly, time-consuming, and challenging for most kids. So as you know, we try to mimic what the body used to do before. So our treatments now for insulin was discovered and used clinically in 1921. From about 21 to around 70, we tried to give as few injections as possible. We didn't do anybody favors because we let them develop severe complications and die at a young age. After that, we started trying to mimic what the body does. So now you see kids are on multiple doses of insulin, multiple blood sugar monitoring. But it's getting a little bit easier with some of the technology. So you examine an 8-year-old named Natalia, who's a Hispanic girl, has recent history of unexplained weight loss. She has increased thirst, recent onset of nocturia or enuresis. Findings on physical examination show mild tachycardia and pallor, which would be the most appropriate blood test here. Blood sugar, right? You find that Natalia's random blood glucose is 350, or urine ketones are negative. So the presumptive diagnosis is diabetes. We talked about yesterday, but I'm going to hammer home the point is if you have diabetes and it's an autoimmune condition, you have to think about other autoimmune disorders. In diabetes, we routinely screen on an annual basis for two of them. One is thyroid disease, i.e. Hashimoto's, and celiac disease. So these occur about 10 to 20% of the time, and celiac's about 5% of the time. And as I said to you, sometimes it's not the individual with the child with type 1 diabetes, but maybe a family member. So it's very common to see a mom who's got Hashimoto's or vitiligo, as we talked about yesterday. But you can have other autoimmune phenomena, so just keep this in mind. So the presentation for diabetes is usually polydipsia, polyuria, and polyphagia, unexplained weight loss. They have decreased glucose uptake, so they have glycosuria and lipolysis. They develop ketosis, and then if this is not picked up, they develop diabetic ketoacidosis. So about 30% of the kids actually present in diabetic ketoacidosis. This is particularly true during the wintertime where you have a lot of a flu outbreak in your community where all these kids are sick and they're throwing up and they go into urgent care emergency room, and you've seen a gazillion of them. Unless you take a careful history, the history here is going to suggest to you that the kid was having problems with polyuria, polydipsia, and weight loss before they became ill. Okay? It's interesting because when we see the kids, we know the diagnosis. We say, well, how did your child how did this first come to your attention? And the mother tells you the child has respiratory problems. Well, that's pretty late in the game, right? So the kid's already mauling by the time they pick it up. So an individual with, one other thing. If you look at kids who are newly diagnosed with diabetic ketoacidosis, so 30% of them, right? So they came in with ketoacidosis. How many of those kids actually saw a physician within the week of their diagnosis? 100% of them. So somebody is missing the diagnosis. So virtually every kid that we hospitalize with severe ketoacidosis has seen somebody within the last 3 to 5 days. So an individual with classic symptoms of diabetes such as Natalia, which of the following would be consistent with the American Diabetes Association's criteria for diabetes? So now the question is, do you know what the criteria for diabetes is? Well, a fasting plasma glucose over 100 would be abnormal, right? Is that diabetes? No. 2 hours glucose 160 after glucose tolerance test, is that diabetes? No. Random plasma glucose greater than 200, is that diabetes? Yes. A1C of 6? No. But this one, that one, and that one are what we call prediabetes. So they're abnormal, they're just not reaching the criteria for diabetes. So a plasma fasting glucose, we just went through this. One of the things that's problematic though is, so if you have a fasting level 126 or greater, 2 hour glucose greater than 200, random glucose greater than 200, this is problematic because the A1Cs in a lot of kids, particularly our obese kids, are greater than 6.5, so theoretically they have diabetes. But interesting enough, you do a glucose tolerance test on them, they're normal. So what do you want to call those kids? We don't tend to label them diabetic in our practice simply because we don't want to put that label on unless it's valid. But we'll give them the treatment for that. We may actually treat them with metformin or lifestyle modification for sure. But I'm just saying in the adult world, they use an A1C of 6.5 and above as a criteria for diabetes. In children, it's not quite as solid as that. So feel free to label them if you want to. It's legitimate. You could say 6.5 and above is going to be diabetes by itself, but I'll tell you that there's some kids who have discrepancies between that and their glucose tolerance test. So prediabetes is defined as a plasma glucose between 100, this is a fasting, 100 to 125, impaired glucose tolerance. If you do a glucose tolerance test, 2 hour glucose is somewhere between 140 and 199, and then A1C between 5.7 and 6.4. Okay? Everybody got the definitions? Most of your kids, most of the Hispanic kids in particular that we see who are overweight or obese, they all have A1Cs between 5.7 and 6.4. Just by the nature of their obesity, they have insulin resistance. Okay? So if you start looking at the difference between type 1 and type 2, this is obviously childhood onset, that's pubertal onset. The ethnic distribution is a little bit different. This can occur in all ethnic groups, but type 2 particularly is prevalent in Hispanic, African American, and Native Americans. So when I was at the University of Arizona for a while, the Pima Indian population in that state, virtually all the kids have diabetes, or will, because all the adults have diabetes. Okay? So there's clearly a genetic component to it, but it's not quite as easy as that. This is an autoimmune phenomenon. This is not. Insulin secretion is very low or limited, and this one is usually low or high. Initially, the C-peptide levels will be low, but when you reduce the glucose, they'll go up. These are usually present with ketosis. This sometimes will. These generally tend not to be overweight. These are. Now, we have so much obesity that we actually have some kids who look like they ought to be type 2, but they really have type 1. So we measure the antibodies in all of our kids, because we got to know if you have somebody that looks like a type 2, you know, they're big, obese, they're Hispanic, and they got acanthosis, they develop ketoacidosis. Well, is that type 1 or type 2? We don't know. But if we measure the antibodies and they have type 1, the point being is they're now required to take insulin because you can't put them on oral therapies alone. And the inheritance pattern, this tends to be sporadic and this tends to be familial. So when you ask family histories of people with type 2, half the family or more has type 2 diabetes. Which of the following statements is true about the distinguishing characteristics of type 1 versus type 2? So youth with type 2 are more likely to present with classic symptoms of new-onset diabetes. In the majority of those with type 1, diabetes-associated antibodies can be demonstrated. Type 2 is rarely associated with obesity, acanthosis. Youth with type 1 are more likely to be American Indian, etc. So you can start reading these very quickly and figure out that's not true, that's not true, that's not true, and this is true. Majority of type 1s have diabetes-associated insulin. Diabetes-associated antibodies. So it's just trying to get you to recognize that this is an autoimmune phenomenon. And just like we talked about with adrenal disease and thyroid disease, you can actually measure those antibodies. Youth with new onset diabetes are more likely to present with the classic symptoms of polyuria, polydipsia, and weight loss. They have demonstrable diabetes-related antibodies, are more likely to be non-Hispanic white than the other ethnic groups, commonly have onset between 2 to 4 years of age, and then again 10 to 14 years of age. Historically, we used to see a seasonality to type 1 diabetes, so we'd see some in the spring and we'd see some in the fall, presumably related to concurrent viral infections. Now it's pretty much year-round. I'll tell you, in our practice in Fort Worth, we see on average, 5 new patients with type 1 diabetes a week. Yeah.
Kind of a strange question. I've had, I don't know, maybe a dozen patients over the years who have severe neuropathies, and their numbers are okay. However, their insulin levels are high. So theoretically, in my mind, it's not the hyperglycemia causing the neuropathy, it's the hyperinsulinemia causing the neuropathy. And how in the world do you help somebody like that? I mean, does a TZD theoretically help?
It's still more likely to be the glucose because the glucose actually gets turned into sorbitol, and sorbitol changes the osmotic pressure within nerves. So you may not see that reflected in terms of glycemic control, but what's really daunting about diabetes, particularly in pediatrics, because we react to really high numbers, right? So in the adult world, you react to numbers that are 156. Well, for a kid, that would be hallelujah, because we ain't been there recently, right? So we talk about numbers that are 250 or more. But I'm just saying that the gradation, the reason these numbers keep coming down diagnostically is because we noted that people who have fasting blood sugars of 112, doesn't sound real striking, but they go on to have the kind of problems you're describing.
So I don't know what to do with these people. They seem almost hopeless because their A1Cs are below 6. Their
Yeah.
insulin levels are high. They pass their 2-hour glucose challenge test.
Right.
You put them on a drug to lower sugar, and they don't like that either.
But you may be starting late. So,
No, they're all late. Yeah.
sorry?
They're all late because they're complaining of neuropathy is the primary.
No, but what I'm saying is you may be starting late in terms of that disease process may have been going on for several years.
Oh, sure.
Yeah. So if I ask you the question, who has the highest morbidity, mortality, premature mortality, type 1 or type 2? The answer is type 2. Yep. A lot more comorbidity conditions and a lot longer before diagnosis. So even in kids, so we have this kind of conversation in our office because every time we diagnose a kid with type 1, the parent says, dang it, I wish it was going to be type 2. No, you don't. Type 2 is a worse disease, ironically. But great question. Youth with new onset type 1 diabetes have a normal or low body habitus usually, but not always. So for example, if we have some obese kids in our clinic and we're having the dietitian see them and she comes running to me and says, gee, you know what, we did a great job. Johnny's lost 20 pounds. I'd say, go check his blood sugar. Right? We'll celebrate after we know he doesn't have diabetes. And the majority of those kids have developed diabetes. Okay. The other thing that's interesting about that type 2 population in kids is that they have this phenomenal weight gain. You've all seen it. And they get to some point, and then all of a sudden, something happened that they outstrip their resources. But they just have this precipitous onset a lot of times that looks like it ought to be type 1. But most of the time it turns out not to be.
But one thing that I've heard is like one mom was like, oh my gosh, she eats terrible, but you know, recently she's just become the best eater. And that's what just threw me off completely, and she ended up having.
Well, not to get too deep in the weeds here, but I will tell you because we're pretty aggressive about working these kids up because we want to know what they look like metabolically speaking. But there are a number of obese children that look like they ought to have god-awful diabetes, and they are perfectly normal metabolically speaking. So to your point, do we do anything with those other than what we typically do, which is dietary counseling, exercise, whatever? We don't have an excuse to do it, but I don't know if they stay that way their entire life. Now, they do put a lot of pressure on their joints. They may or may not be happy with who they are, but at the end of the day, metabolically, I can't justify putting them on medication.